her name. Wow, I like to see this. This is full. So thank you so much for attending. I have just a couple announcements. I do have some money to give away to start the day. I do want to thank everybody. We couldn't do this without you. So give a round of applause to yourself and to the vendors for signing up. This is great. This is the most attended conference that we have post-COVID. So I'm excited for this year's events. One detail I want everybody to know. So sad news, we won't have coffee all day in here, but we do have a specialty coffee latte vendor that's with us in the vendor hall. So today, throughout the day and tomorrow, they'll have specialty lattes, coffees, and teas. So please see that and support our vendors. Okay. Who traveled the farthest away? Kentucky, okay, we got Kentucky. Kentucky also. Iowa. How many? One or two from Iowa? South Dakota. Oh, sorry, Kentucky. Close. All right. Well, congratulations. You get cold hard cash this morning. Thank you for traveling so far. I know we have some from also Ohio here too. I don't know if they're in the house yet. All right. Well, you guys. Oh, yeah, I can do the intro. All right. I got distracted, ADHD. All right, we'll keep going. All right, let me introduce you to Tony Ross. Tony Ross is an accomplished professional with over 2 decades of experience in the medical device and healthcare industry, specializing in project management, program leadership, and operational excellence. Currently serving as product manager for SleepRes since September of 2024, he drives the strategic planning, development, and successful launch of innovative products and solutions with expertise in medical devices and product operations. Prior to this, as senior program manager, sleep at Apria Healthcare from 2021 to 2024, Tony led cross-functional PAP adherence teams. Before joining Apria, Tony had extensive tenure at Philips Respironics from 1999 to 2021, including roles as senior field marketing manager for services, product support manager from 2007 to 2010, and technical support specialist. Tony's career reflects a commitment to advancing sleep health solutions through strategic oversight and stakeholder collaboration. So thank you so much, Tony. I'm winded from that, man. That's impressive. Thank you so much.
Thank you. That is a lot. It makes me realize how old I am now. All right. As he said, I am Tony Ross from SleepRes. So quick show of hands. Who has heard of SleepRes? Very few, very few. Well, we are a newer company. We are part of the vendors back there, so please stop by if you get a chance to see what we're doing. And that's really a little bit about what we're going to talk about what we're doing. So today's learning objectives describe KPAP and the benefits for OSA. So you may not have heard of SleepRes, but who has heard of KPAP? All right, there's a few more hands. I like that. Understanding the negative impact of expiratory pressure relief. Everybody knows about EPR and C-flex. We're going to talk a little bit about the negatives around that. And recognize how reduced inspiratory pressure can lead to a more natural transition for OSA patients. Yes, you heard me right. Reduced inspiratory pressure, right? So we like to think we're turning things on its head when it comes to CPAP therapy. All right, so dating myself and along with a lot of others here, if you think back 30 years ago, have we really made CPAP better? Yes, no. I mean, one of the CPAPs I originally started working on, my first job at Philips Respironics as a service tech, was this device. Who remembers this device? Right? There's slots in the top and the side. Kids used to think they're piggy banks and used to put pennies in there and short everything out. It was always great. 6 pounds, 9 inches high, 5.75 inches wide. We've gotten smaller. You think about the AirSense 11, right? 2.5 pounds, 10.2 inches long, and 2.72. So we've made them smaller. Definitely smaller than that machine. Definitely smaller than that machine. So if you think, devices are smaller, they're quieter, they're humidified, they're pressure auto-adjusting. Masks, think about masks, they're smaller, lighter, more options and sizes than we've ever seen. Again, we'll go back into the vendor area and you'll see masks galore. They're all great masks, but there's just a lot of them, right? But have we made the pressure delivery more natural and more effective? Right? We're making everything smaller, we're making it quieter, but have we really done anything to the pressure delivery? And if you think about it, all attempts at improved comfort has been focused on lowering the expiratory pressure, right? EPRs, C-flexes, things like that. Everything's been focused on expiratory. And really the question is why? And it's about reduce the work of breathing, right? So if you think about BiPAP, your square wave, right? We're reducing the expiratory. C-flex, see that little back pressure, drops it and increases it back up. And EPR is similar to BiPAP, just not as big of a drop, right? Just a square wave. And higher IPAP really supports inspiration, and lower EPAP reduces the work of expiratory work. That's what's happening there. Who here is, and I'm going to ask a lot of questions. I like to try to get everybody involved. Who here has heard of TEXA, Treatment Emergent Central Sleep Apnea? Not many, right? A few. I see heads nodding. So there was a study of the flex and EPR algorithms that found that TEXA, which is Treatment Emergent Central Sleep Apnea, increased by a factor of 8. So if you think, right, a lot of us, a lot of people here are sleep techs. We know what central sleep apnea is. But did we really see the influx of central apnea until the flex and the EPRs really came out, right? It existed, but it wasn't as prevalent as it is today. And so when you look at the study, group 1, 473 patients, 16 had treatment emergent central sleep apnea. Yeah, it's only 3.3%. It's not, massive. But if you look at the group, it was just on CPAP, only 5 patients out of 1,158. So again, what you're seeing is there is a negative effect to dropping the expiratory pressure. And that negative effect is treatment emergent central sleep apnea. So when you think about lowering EPAP, it really hasn't done anything to adherence, right? I mean, everybody's widget fixes adherence, everybody's apps fixes adherence, everybody's got a claim. But when you really look at the data, adherence is really the same as it's always been. So lowering EPAP typically leads to decreased pharyngeal cross-section area, decreasing dilating force. This is a lot. If you understand it, great. We'll get into it a little bit. But lowering EPAP also reduces end expiratory lung volume with lower tracheal traction. Really, it's the stiffening of the airway. It's stretching it and stiffening it. And higher IPAP does not effectively dilate the airway. Lowering EPAP means that IPAP is greater than EPAP, right? I mean, that's what's happening here. So it means pressure support. And pressure support in patients with high loop gain can yield unstable ventilatory control with central sleep apnea. Again, TEXA. So typically, if you've got a patient and all of a sudden you put them on CPAP, you've got EPR, you've got flex turned on, and you start seeing a lot of centrals, or you see more, first thing you should be doing is turning off that flex, turning off that EPR. More than likely, that centrals are happening because of that. So I talked about decreasing dilating force, and then hopefully you can see these little red circles here. So on the last slide, I talked about a reduced pharyngeal cross-section area. Try saying that 5 times. It's a narrowing of the throat, right? And so really it's significant anatomical factor in the development of obstructive sleep apnea. The narrowing increases airway resistance and pharyngeal collapsicity. So what we're saying here is if you look at these patients, right, and we lower EPAP. So if you look at EPAP, where we lowered it 0, and you look at spontaneous breathing, right, it's almost a circle. It's almost a circle. Once you start decreasing EPAP, so you start putting EPAP in, it starts actually showing like a square and almost like a rectangle, right? So what happens if you think about it? An apnea occurs when the airway collapses, right? So if I am at 0, I've got a circle. I've got a lot more to collapse down for an apnea to happen, right? So you've got a circle, it's got to come the whole ways down. Where if I've got almost an oval, it has less that has to come down to create the apnea. So that's what's happening here in this study. They actually had a trait scope down into the airway, measuring the diameter of the airway. So right here, at EPAP of 15, you can see it's more of an oval. So it's more likely to collapse and cause an apnea. Took me a long time to figure that out. All right. And this here also shows here. So if you've got decreased IPAP, increased flow limitation. So here's a BiPAP of 11/8, 11/9, 11/10, 11/11. So you've got your pressure, your mass, but here's your airflow. And look at your airflow. It's very low. It starts increasing as I'm increasing the EPAP. But once I get to a BiPAP, basically, or a CPAP of 11/11, my airflow is very nuts. So it's very high. You know, you're getting your inspiratory, your expiratory, everything flows very nicely. So you can see here, even from the airflow, how BiPAP, lowering the expiratory pressure, you've got lower flow. And then once you get to CPAP, you've got a nice flow rate. So in conclusion, lowering EPAP compromises pharyngeal patency, contributes to the development of TEXA, and in general does not improve PAP adherence, right? So there's little reason, if we think about it, to ever really use, and my BiPAP got cut off there, C-flex, EPR, or BiPAP. I know this goes against everything you've been taught for probably the last 10 or 15 years, right? All right, so SleepRes, what if, you know, for us, what if we lower the inspiratory pressure, right? Again, turning everything on its head. So will lowering IPAP be a positive or a negative for patients? OSA patients, not obesity hyperventilation patients, do not require ventilatory support, right? They do not need a IPAP greater than EPAP. And controlling one's own inspiratory flow rate, lower IPAP, could be more comfortable than having a PAP machine do so. Again, higher IPAP. So why is lowering IPAP more natural? Sorry, I was just thinking, I hope I'm not in your way. All right, so unchanged pharyngeal patency, the ability for the pharynx to remain open, allowing for clear airflow during breathing, right? So keeping that open. Less positive pressure allows for more natural breathing sensation, right? Breathing on CPAP is not normal. I don't care what anybody says, it is not normal. But lowering the IPAP does create the sensation that it is a little bit more natural. Normal diaphragmatic contraction. So the diaphragm flattening and moving downward increases the volume of the chest cavity, which lowers pressure to draw air into the lungs. So again, pushing it down increases that volume of the chest cavity. And then the chest wall itself, expansion rate and extent of the chest wall are more normal. So when we lower IPAP, all that actually occurs. So this is our founder, Dr. Bill Noah. I don't know if you've known him or seen him do any presentations. You know, during COVID, he really went into what I'd call research mode. And he really dug into all the studies that are out there, all the papers, and he's the one who really figured out, what if we lowered inspiratory pressure instead of expiratory? So he created what is called the VCOM. Who here has heard of the VCOM? All right, more hands. That's probably the most I've seen. All right, so he created the VCOM. And again, it's all about the theory of IPAP is lower than EPAP. And I always like to show this. This is actually the first one. He did it at you know, 3D printing of the VCOM right there. You know, so he designed it, 3D printed it in January, he redesigned it, injection molding, all that fun stuff. And then really at APSS in 2022, launched the VCOM. When you were there, if you were there, the line from the booth was huge. Everybody wanted to know, what's that little piece of plastic, right? They all wanted to see what it was. And really that's it. And it's really an inline resistor that goes right where the mask goes to the tubing. So it decreases the inspiratory pressure, but does not impact the expiratory. So it's really PAP breathing backwards, decreasing peak inspiratory flow, helping patients to acclimate to therapy. It can be taken out when peak flow can be tolerated. So it's not something that patients have to leave in all the time. But what we do find is patients who use it tend to like to keep it in their actual system, in the airway. They take it out. Some do take it out because they can now withstand the CPAP pressures, but a lot of patients tend to leave it in. So how does the VCOM really work? So this is without VCOM and this is with VCOM. So this is the mask pressure. This is the pressure actually at the mask. So again, you heard me say it, it's a resistor, much like other components, right? If you think about if you're familiar with electricity, air's got to flow 6 feet. It's got to flow 6 feet. It's going to decrease its pressure. It's going to decrease its flow. So it's an inline resistor like other items in the PAP circuit. It impacts flow at its highest point, which is inspiration, right? When you breathe in, that's when the flow is the highest. Patients experience what they call a softening of that flow. I always say, inspiratory, put your head out the window of your car when it's going fast. You can't breathe. I don't know how my dog does it, but my dog can breathe. But that's what's happening, right? We're softening that flow, that burst of air. And the VCOM utilizes the science to provide comfort without compromising therapy. So again, if you look at the mask pressure, it's a little all over the place, very low. With VCOM, nice and steady. So does VCOM affect therapy? That's typically the one question we always get, right? I put this in the circuit, what happens to the therapy? What happens to the AHI, right? What happens to pressure? So we did a study, participants, about 101, we looked at their P95 pressure, 11.5 with no VCOM, 11.7 with VCOM. We looked at AHI events, 1.78, 1.47. Yeah, it's a little lower, but really it's not significant. Leak, definitely a lot lower. And if you think about it, you're reducing that inspiratory flow, your inspiratory pressure, you're likely to get less leak. I always sit there and say, look, we're not really here to tell you that we're better. We're going to be, AHI is going to be better. We're not, but we're going to make it more comfortable for patients to use. So when you look at that, P95 is the same, events are just about the same, but we do reduce the leak, and that can be a problem with patients and their spouses or their partners. So VCOM is an accessory. Does not require a prescription. It is a cash pay item. I know React Health includes it with some of their devices as well. VCOM is an accessory to the PAP circuit. It goes right in line. Indicated for use in CPAP and APAP. VCOM is not recommended for bilevels, ASCs, or ABAPs. Okay. It is FDA registered type 1 device and it is manufactured in the USA. I think the big thing here is no prescriptions required for this. Some DMEs offer them, some don't. Patients might hear about them. It's a great opportunity if you have patients who are struggling with therapy from a pressure standpoint to offer something like this. And I don't have it in here, but typically you can add up to 2 VCOMs. One VCOM reduces the pressure 1.8 centimeters. And if you add 2, you're at 3.6, right? So you can add 2. We don't recommend more than 2, but if you've got a patient who's maybe CPAP pressures at 15, you can put 2 in line. So, talked about VCOM, we talked about everything, but let's talk about the new PAP, KPAP, pressure at the, just in case anybody ever wants to know, KPAP stands for Kairos PAP, and Kairos is the Greek word for pressure at the right, well, it's for the right, at the right time. So, I should have just went to the slide. KPAP is a new algorithm within the CPAP machine. I always say, think of it as Intel. Right? We're not creating a new therapy, if you will. CPAP and APAP are still there. We've created an algorithm that will reduce the inspiratory pressure for the patient in the machine. So take the VCOM, put it in the machine, that's what we're sort of doing. So let's walk through how we do this. So with KPAP, it's optimized for natural breathing, right? So at the beginning, I love that I have a laser pointer. So this is the beginning of the inspiratory breath. We drop the pressure 2 centimeters and then 3 centimeters for a 5 centimeter drop. So if you're on 10, during your inspiratory breath, you're dropping it, and at the end of your inspiratory breath, you're down 5 centimeters, so you're down to 5. We hold that throughout the beginning of the exhalation, and about mid-exhalation, right about there, we start to go up, we transition up. And so if you look at the end of expiration, that is where all apneas occur. We are back at the CPAP pressure. So again, if you're at 10, we drop it 2, 3 to get to 5. We ride that 5 halfway through the exhalation, and then we increase it. So at the end of exhalation, you're back at your 10. And again, most apneas always occur, most if not all, at the end of exhalation. So at the end of exhalation, we're back at the CPAP pressure. So if you look at a few breaths, if you will, here's your inspiratory, drops, rides it, goes back up at expiratory, goes down. Always there's a sort of the reverse of what's going on today in a lot of these machines, right? So it's during inspiratory, we're dropping it. Now, I will go back here. A couple of things. We don't go more than 5. There is a custom setting that you can adjust if you want 2 and 1 or 2 and 2. So we don't go more than 5, and then we never go below 5. So if the patient's set at 8, we'll only go down to 5. So it would be 2 and 1, right? So we never go below 5. So, okay, great, you've done that. How do I know it works, right? So let's talk a little bit about the clinical trials. So efficacy, again, you heard me say it earlier, I'm not trying to be better. We are not trying to be better than CPAP today or APAP, right? We're just simply trying to figure out a way to make PAP therapy more comfortable so patients will use it, right? You heard earlier, I worked at Apria for 4 years and dealing with patients on why they wouldn't use CPAP. Number 1's always the best, but number 2 is always the pressure. And so if we can make it more comfortable, will patients possibly use our machines more often? Become adherent. So we did a study, 50 patients with documented OSA, stable APAP, and they typically slept 6 hours or more. They reported to a sleep lab for a full night PSG in random order, and half the night was on CPAP, set at their P95, to determine from the PAP device at home. It was determined from the PAP device at home. And then half the night on KPAP, set at the P95, with a 2 centimeter and a 3 centimeter drop, so a total of 5. So there's a lot here. I always sit there, I don't know if you know Dr. White, David White, he's our chief medical officer. I always tell him I have no clue what that does. But what it means though is if you look at the age, and events, if you looked at it on a SpO2 drop of 3, CPAP had 3.9, KPAP, it was in between these ranges, if you will, 2.9 to 4. So p-value of minus 0.06. Nothing significant, right? Again, I'm not sitting here trying to tell you we're better, but what we are is we're equal to. And then if you look at SpO2 drop of 4, 1.0, 1.5, 0.8, 0.1, p-value minus 0.2. Again, very equal to what a CPAP is doing. We also then did a comfort study. So we had 150 patients. I know, that's a great picture, ain't it? That's my dog. Not my dog, but I feel like that's my dog. So we did 150 patients with recently diagnosed OSA. Really what we did is a couple things. We put them on a CPAP pressure of 9 centimeters and 13, and KPAP 9 and 13 with various pressure drops. And the outcome was really patients selected KPAP more often. So if you look at it, this is 9 centimeters, this is the 13. So at CPAP, at 9 centimeters, 11 patients take CPAP. With a pressure drop of 1 and 1, so a total of 2, 14 patients selected that. KPAP, 1 and 2, 21, and then 2 and 2 was 104. And then at the pressure of 13, we still had 10 patients pick CPAP, 5 at 1 and 1, 11 at 1 and 2, and KPAP 2 and 2. So if you think about it, roughly 93% of patients found KPAP to be more comfortable than CPAP. And again, that's part of the name of the game, right? Get them comfortable on therapy. Also, side effects, unintentional mask leak. So if you think about it, I always sit there and say, look, there's all these masks, no matter what, we get leak. I don't care what you do, there's just leak all the time. But if you can decrease the pressure, the inspiratory pressure, you have the opportunity to decrease the leak. And that's what we found. So KPAP reduced the mask leak compared to CPAP roughly 50.8%. So by just simply implementing KPAP, the inspiratory pressure was less, causing leak to be half, right? And again, that reduction in leak represents a significant improvement. Leak is another issue we have with getting patients adherent to therapy, right? If the mask is leaking, that's always one of the problems with those masks. Also, I like to say this is the jetting, and I know my F&P friends are here. I'm just calling out a pillows mask. So if you think about a pillows mask, I've sat in these rooms with you guys, patients come in, I always say it was the dessert tray effect, right? They bring out that dessert tray and there's 20 desserts on it. Which one do I want? I want them all. A lot of times patients walk into an office and you've got all these masks on these display heads, right? And it's the dessert tray effect. Which one do you want? They always go for the smallest one, right? They don't want the full face mask. They don't want the nasal. They want the pillows. But a lot of patients struggle with pillows. And a lot of it is because of the jetting effect. If you think about the pillow, you're going from 22 millimeter down to a little hole going into the nostril, causing sort of a jetting effect. And I always say it's sort of like putting your thumb on a hose. So what we found is with reducing that inspiratory pressure, patients are more tolerable of pillows masks because you're not getting that jetting effect anymore with those masks. So it's an opportunity to get patients on those lighter, smaller, quieter masks versus them, again, throwing a full face mask on everybody. And ease of exhalation, so patients find exhaling is easier. So I always sit there and say this. So again, going back to EPR, right? We drop here, hold it, we raise it back up at the inspiratory. C-flex, we drop it, but there has to be a back pressure, right? So you have to back pressure against the machine for it to drop. EPR is just a small BiPAP, if you will. C-flex is very similar. With ours, if you're on the auto mode or the total of 5, so if you think about it, a pressure of 10 with an EPR of 3. I'm 10, I back pressure, it drops 3, so I'm at 7. But it's, again, I still have to force it to go down. Same thing here, C-flex of 3, I'm on 10, I'm gonna push it, and get down to about 7, and start to increase. With KPAP, we're at 5. And there's no back pressure that has to occur for the pressure to actually drop. Because once the expiratory phase starts, the patient's already 5 down. And so patients tend to find that the exhaling against KPAP is a lot easier than the others. So in conclusion, KPAP has the same efficacy in treating OSA as a standard in CPAP despite dropping the pressure 5 centimeters. Patients initiating PAP therapy virtually all found KPAP more natural to breathe on compared to CPAP. And I like to think of this quote from John F. Kennedy: change is the law of life, and those who look only to the past and present are certain to miss the future, right? We're all set in our ways. We are. Change is hard. And so I encourage you to come back, look at the Cricket device. That is the name of our device. Look at KPAP. KPAP is the Intel inside. And obviously we are pending 510K, but please stop back. Love for you to try to breathe on it. We've got masks and everybody can get to try it, but KPAP, again, it's really the opposite of what's happening out there today. All right. We take questions. All right. Thank you.